Hi again, I'm Melinda Stanley. I'm a retired psychologist and emeritus professor of psychiatry and behavioral sciences at Baylor College of Medicine. I'm also a prior researcher with the Michael E. DeBakey VA Medical Center here in Houston. And today I'm going to be talking about anxiety in older adults. This will be our part two of a two-part series. The content is brought to you again by the Southeast Texas Geriatrics Workforce Enhancement Program, a collaborative program between Michael E. DeBakey VA Medical Center and Baylor College of Medicine in partnership with other academic and community service organizations. The project is one of a network of 48 nationwide GWEPs supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services. Our aim is to improve health outcomes for older adults by developing a healthcare workforce that maximizes patient and family engagement, by integrating geriatrics and primary care along with the 4Ms framework to create age-friendly healthcare systems. So thanks for joining today. And we will now move to our slides. This presentation, as part one, was prepared by myself and Dr. Kraus Schumann, Dr. Mark Kunick, who are geriatric psychologists and psychiatrists, respectively, working in the VA. In part two, we're going to be talking about assessment of anxiety in older people, what to assess, what screening measures might be good to use, and again, addressing the overlap between anxiety and medical conditions. We'll talk about medication, we'll talk about psychotherapy, focusing mostly on cognitive behavior therapy, and we'll talk about a few case examples. Again, we're going to organize our information within the 4Ms framework, talking about what matters to the patient, aligning our questions and our treatments with their values and their beliefs and their descriptions of the symptoms, including their family members when appropriate. We will talk about age-friendly medication strategies and attention to medical problems. We will talk about screening tools that you can use for older adults with and without dementia. And we'll talk about mobility. How can we encourage people to stay active, to reduce avoidance that is often associated with anxiety, and monitor fear of falling. So we'll start with assessment. The most important part of assessment is the initial clinical interview. And we will address all 4Ms in an interview. We will talk first about symptoms, not just what symptoms the person is experiencing, but how often, how intense, how much distress is associated, and how much impairment. We'll also want to know about onset of these symptoms relative to onset of medical illness, uses of medication or other substances, and cognitive impairment to try and develop a timeline and look at overlap between anxiety and these other issues. We'll want to know about past anxiety symptoms and treatment. We'll want to know about medical history, current medications, and stressors. And the timeline of stressors also is important as it relates to the experience of the symptoms. And then we will consider whether we want to use some standardized measures, and I'll talk about a couple of those in a minute or two. When we're evaluating anxiety in a clinical interview, we also want to ask about depression. There's a lot of overlap. We've talked about that, and we'll talk about it some more today. We want to ask about suicidal ideation because this is an important issue, not just for people who have depression, but also for people who have anxiety. We want to know about substance use because using substances can sometimes be an anxiety coping mechanism. I feel anxious, I have a drink, I feel less anxious. And using substances can actually create anxiety. So that's an important thing to assess. We want to rule out delirium, medications and medical conditions that are creating the symptoms, and gather information from family members, as is common for most of our work with older people. I want to mention two specific measures of anxiety that might be useful for incorporating into your practice. The General Anxiety Disorder Scale is a measure that was actually developed for younger adults, but has been used frequently with older adults with a lot of success. It's got good, what we call psychometric properties. The GAD-7 is a 7-item self-report measure that was developed in primary care as a brief measure for worry and anxiety. Each of the 7 items requires a response on a 4-point Likert scale to evaluate severity of symptoms over the past 2 weeks. I include here a link to the measure, which is also in the toolkit that accompanies these slides. The Geriatric Anxiety Inventory, GAI, is another measure that is frequently used for older adults, and it was developed specifically for older people. The original measure was 20 items, which is a little long. There is a newer version that is only 5 items that is much simpler to use. The benefits of this measure are that it is designed around a yes-no response format, so an older person doesn't have to decide, do I have a little, a lot, a medium amount? You don't have to use a 4-point Likert scale. They just say, yes, I have this, or no, I don't. And it minimizes the emphasis on somatic symptoms, so then there's less overlap with evaluating physical health problems. The drawback to this is that this inventory requires a request for use and a commercial license. In part 1, we talked about the high amount of overlap between anxiety and depression, cognitive impairment, and medical illness. But let's focus a little bit on this in more detail with regard to assessment. When we are trying to differentiate anxiety from medical conditions that may create anxiety-like symptoms, we want to know what medical conditions the person has, and we want information about the relative dates of onset for anxiety symptoms and the medical diagnosis. So we can kind of, as we said, put together a timeline of symptoms to help us decide how much overlap there is and how much difference there is in the medical diagnosis, the symptoms of the medical illness and the symptoms of anxiety. Similarly, we want to review medications and the timeline for use of those relative to anxiety symptoms. Here are some common medical conditions that cause anxiety-like symptoms and the list of symptoms that are associated with those. These are things you're all familiar with: respiratory problems, thyroid problems, cardiac problems, substance withdrawal problems, and the types of symptoms that these illnesses can create that may look like anxiety and overlap with anxiety. Here are some medications that also can cause anxiety-like symptoms: anticholinergics, antidepressants, beta agonists, steroids, etc., and some examples of those medications that can create symptoms that look like anxiety or that may be experienced as anxiety. So important to look at all of these medical conditions and medications and see how the anxiety symptoms were experienced around starting and stopping and exacerbations and improvements in these issues. Assessing anxiety in individuals with dementia is complicated for a couple of reasons. First of all, because the symptoms may present differently and they may be experienced differently. So older people with cognitive difficulties may have more restlessness, more repeated questions, more irritability, more fatigue, sleep, disturbance problems. They may not as easily be able to report what they're experiencing internally. That means it's particularly important to have some caregiver report. Caregivers may not know what's going on internally, but they can help identify behavioral symptoms of anxiety that may be less prevalent in your office or when you're doing assessment, but may be prevalent at different times of the day or in the person's everyday life. Let's turn now to treatment of anxiety in older people. The best news is that evidence-based treatment does exist for anxiety in older people. The 2 major types of treatment are the same as the types of treatment we use for younger adults: medication and psychotherapy. Some older adults prefer medication. Medication is also more widely available, and probably the effects of medication more often occur more quickly for older people. In most cases, though, once the medication is withdrawn, the symptoms come back. Psychotherapy may be preferred by some older adults. I list here a number of types of therapy that are effective for anxiety. We're going to talk mostly about cognitive behavior therapy, or CBT, because it has the largest empirical base for efficacy in the treatment of anxiety in later life. The first step in any treatment decision making is more education. Education, we talked about in part 1, is particularly important for older people who have less awareness of the symptoms of anxiety and less knowledge of the treatment strategies and effects. Good psychoeducation promotes good treatment adherence. So if we explain more clearly what the treatment is going to entail, what it will be expected to do, we're more likely to get good adherence. Involving family and caretakers is also important whenever possible. The things that we need to discuss when we're educating patients is, first of all, this overlap between anxiety. Well, first of all, what is anxiety and how does it overlap with your health issues? And what is the truth? Kind of what is fact and what is fiction with regard to your beliefs about anxiety and about health conditions? It's also important to inquire about mental health stigma. This is more of an issue for older people even than younger people. And important here to address any concerns or misbeliefs about mental health and its treatment, to attend to individual and cultural differences in the perspective that patients and their families may have about anxiety, mental health, and mental health care. We, of course, when we're educating a patient, want to review our diagnostic impressions and talk about the positive effects of anxiety treatment, talk about treatment options and follow-up plans, and side effects if we want to incorporate medication. All right, so if we're going to consider medication for our older patients with anxiety, more education, right? It's becoming a theme, but it is important to make sure that a patient understands what's to be expected with the medication, both positive and negative. Sometimes we see a pretty hefty placebo response with medication, so we will sometimes see a very quick response, maybe even quicker than would be warranted with the medication. Medication does have generally a quicker effect than psychotherapy, but it can take weeks to months for the full effects to be experienced. Most of the medications that we're going to talk about are pretty well tolerated by older adults, but they do have some side effects, so it's important to educate about that. And there are a number of medications that are effective for anxiety in later life, so if one doesn't work, we can try another one. General recommendations that we make for using medication in the treatment of anxiety in later life: first of all, avoid benzodiazepines if at all possible. Benzos are effective for anxiety. They do lower anxiety, they do work quickly, but they have very serious potential side effects for older people. They decrease cognitive abilities, they increase motor retardation, which leads to increased rates of falls and motor vehicle accidents. So we want to avoid them as much as possible. We also recommend becoming familiar and comfortable with the use and side effects of SSRIs and SNRIs. Maybe choose one in each of these categories that you feel very comfortable with and know well. But probably more important than which medication you choose is understanding the philosophy that we want to start at a very low dose and gradually increase until we see a response. Here are some medications commonly used for treating anxiety in older people. We have the SSRIs, and there are a few listed here for which we have evidence. SNRIs, likewise, a couple for which we have evidence. And then buspirone and mirtazapine that are used usually when an SSRI or an SNRI has not been effective. We want to, with all of these medications, start with we want to start with an initial dose, but we want to work toward the lowest therapeutic dose that provides a response to avoid psychomotor agitation that can occur with the use of some of these medications. And many older adults will respond to these lower doses. Here's an example of how you might use a medication with an older adult who has anxiety. Let's say you're choosing sertraline. That's one that you're comfortable with. You start with an initial dose of 25 milligrams. If that's tolerated in the first week, then you increase to what might be the lowest therapeutic dose, so say 50 milligrams. If that's well tolerated, then maintain that dose for 4 to 8 weeks and see what happens. If there is a robust response, great, there you go. If there is not a robust response at this time, then perhaps increase the dose again, 25 to 50 milligrams every 2 weeks until there is a robust response, or until you have some intolerable side effects or you reach the maximum target dose. For sertraline, that would be 200 milligrams. If, when you have the lowest therapeutic dose, you have no response, probably the best strategy is then to taper that medication and start another one. There is no evidence that switching to a different class, so switching from SSRI to an SNRI, is better than staying within the same class, but switching to another medication that you feel comfortable prescribing is fine. If there is a partial response in that 4 to 8 weeks, or by the time you get to the highest dose, if there's a partial response at the higher dose, you might consider augmentation with Buspar or with CBT. Okay, and how about psychotherapy? Psychotherapy also can be effective and can be used with medication or on its own. To prepare for developing a psychotherapeutic treatment plan, we want to know, again, in terms of what matters, what symptoms cause the person the most anxiety or worry or concern, and what does anxiety interfere with the most? Does the worry, anxiety cause the person to feel sad? So do we have coexistent depression that we also need to address in our treatment plan? And do we have any helplessness or hopelessness that needs to be incorporated and assessed as we go through our treatment course? And as we've been talking about anxiety, we've talked often about the frequency with which avoidance is a problem. So we want to know which things the person is avoiding because they've been fearful. We also want to know what pleasurable events they've been avoiding so that we can incorporate this into our treatment plan. If you think that therapy may benefit, there are multiple ways to find a provider if you don't have a relationship with someone already. I list here in this slide, and there's also a list in the toolkit that is available to accompany these slides, the different organizations through which you can obtain a referral. It is sometimes difficult to find a therapist with expertise in older adults, although probably more easy to find a therapist who knows something about anxiety, but important to find someone who knows how to deal with that in an older person, if possible. What would psychotherapy look like? There are some older adults for whom no adaptations are needed. They can do the therapy the way it's done with a younger person. For others, however, it will be important to individualize the treatment to meet content and process differences that are needed. Older adults may need more psychoeducation. We've kind of harped on that, but that may be important to spend a little more time at the front end helping the person understand what the treatment will be about and how it is expected to help. Attention to age-related concerns, avoiding ageism is important in the content. Significant anxiety is not a normal part of aging, and it is something that can be improved. Sometimes we need to do therapy at a slower pace. We may need to adapt to an individual's learning style. How do they learn best? By seeing, hearing, doing. We need to attend to the environment in which they're learning and practicing. Is it a quiet place? Can they practice in the situations that create anxiety? Using memory aids and attending to sensory changes can be important. Sometimes we use much larger print on our measures and our homework forms, skill reminder cards that can be placed around the home, and again, collaborating, we'll talk some more about this, with other people in the person's environment. The latter is particularly important when you're trying to do psychotherapy with a person who has cognitive impairment. In these cases, the family member or caregiver can be trained to be a coach to help the patient practice using some coping skills. Particularly for older adults with cognitive impairment, we want shorter sessions to maintain attention. We want a slower pace. We want to simplify the skills to very basic steps with more focus on behavioral skills and less on cognitive or complex skills that require complex thinking. We want simplified summary sheets of the session to use as reminders and practice, skill summary cards and reminder cues that can be put in places around the person's house. There is a small body of research that demonstrates benefits of cognitive behavior therapy-based interventions for anxiety in individuals with dementia. And there are a couple of programs available that are in your toolkit. We wanted to talk just a little bit about what cognitive behavior therapy or CBT might look like, since it is one of the primary modalities that can be beneficial. Cognitive behavior therapy focuses on changing thoughts, physical symptoms, and behaviors that create or are associated with anxiety. The idea here is that it's very difficult to just change an emotion. It's hard to just change anxiety all by itself. Easier to change the way a person behaves or thinks or experiences physical symptoms that will then reduce feelings of anxiety. There is research that demonstrates positive effects of CBT for generalized anxiety disorder, panic disorder, PTSD, anxiety symptoms, and associated depression in older people. Primary features of CBT involve a patient and a therapist really working together. It's a collaborative kind of process where they set goals, evaluate outcomes, share feedback, and work together. Treatment is very directive, time-limited, structured, and problem-focused, almost like a class. So older adults with feelings of stigma about psychotherapy may be more willing to take a worry class or an anxiety class or a stress class that involves CBT principles. So focus in CBT is on the present. We don't ignore the past. We think about, as we said, the timeline and how did the symptoms begin, but we're focused mostly on what symptoms are you having and what skills can I teach you to help you manage those. Homework or skills practice, whatever term the person prefers, is important for people to learn to use the skills that will improve their anxiety. So step one in CBT is to identify the thoughts, physical symptoms, and behaviors associated with anxiety. If we don't know what these are, we can't change them. For an older person, for example, experiencing panic attacks, they might have physical symptoms that include heart pounding, heart palpitations, increased heart rate, stomach upset, GI difficulties, dizziness. They might have a thought when they get this sudden surge of these physical symptoms, I must be having a heart attack, I'm going to die. And then they may begin to avoid certain things, certain situations that provoke these symptoms. So they may stop driving on the highway. They may stop going to church or meetings. They may stop their volunteer work because they're afraid of having a panic attack. Step two then is to help them change the thoughts and behaviors to reduce anxiety and depression. We work on changing thoughts to help people learn that the pounding heart, the palpitations, are actually a symptom of anxiety and not necessarily a symptom of a heart attack. We can teach them how to change the actual experience of the physical symptoms by teaching relaxation strategies, deep breathing, imagery, other kinds of relaxation, mindfulness, strategies that can be used to actually slow the heart rate, reduce GI distress, decrease dizziness. And then once people have learned to use some skills, we then ask them to confront the feared situations, to go back into the situations that they've been avoiding, use their skills, their thought and physical symptom skills, and allow themselves to decrease the anxiety and return to activities that they have enjoyed in the past. We teach a variety of skills, and therapists can call on any of these. Psychoeducation, self-monitoring involves keeping records of your anxiety. When did you feel anxious? How anxious did you feel? What were you thinking? What were you doing? What physical sensations did you have? Can be a very useful way of helping a person understand their own patterns of anxiety and the cues for those. We can teach relaxation skills. People love to learn deep breathing. We can teach them how to change their thoughts. We can teach them how to sleep. There are many strategies about how to live your day in a way that improves your sleeping. When to take naps, when not to take naps, when to eat, when to exercise, etc. What to do when you wake in the middle of the night and can't go back to sleep. Problem-solving skills training can really be useful. Very many times when people are worrying about something. They're thinking, what if this, then what if that, then what if that, but then I think, what if this, and they're kind of going all around in circles with regard to the issue they're worrying about, and they're not actually doing any productive thinking about that. So if I'm worried about finances, I can get caught up in my ruminations about that without actually looking at how much money I have, which things I need to buy, and how my money is going to fit my needs. Exposure treatment, this is part of treatment that focuses on avoidance, going back into the situations that make me anxious that I've been avoiding, and practice some of these skills to allow myself to enjoy these situations again. In recent years, we've been studying, learning how to do CBT in a lot of different ways. This is particularly important as we have more people staying at home because of this current pandemic. We've learned to use treatment in a modular way so that not everybody needs to learn all the skills. They learn the ones that are the most appropriate for the symptoms they're experiencing. We've learned about integrating religion and spirituality into CBT for older adults. Many older people are very tied to their religious values and their spiritual practices, and these can be incorporated into cognitive behavior therapy to reduce anxiety. Involving other people to serve as a coach, we've talked about that. Delivery option, the traditional way of delivering CBT was in a mental health clinic with a PhD level provider. Well, that's not the only way we do it anymore. We can do it in primary care. We can use community settings for administering worry classes. We can use non-traditional providers, caseworkers, community health workers. We can deliver the treatment over video conference and telephone, which is particularly important these days, but it works well in all of these modalities. Let's do one case example and then a couple of practice before we end. So we have a patient named Maggie. She's 65 years old, recently retired. She has COPD, and she has some anxiety symptoms that look like this. She has panic attacks mostly in the afternoons. They increase her respiratory rate. She's afraid she's going to have a heart attack. She's afraid she's going to die. So she calls her husband at work for reassurance. We've talked about repetitive checking. She calls him to see if she's okay. And she is now starting to stay home all day because she's afraid if she goes out, she'll have a panic attack and she'll be in a car, or she'll be with friends and she'll be embarrassed, or she'll die and she won't get the help she needs. A very severe panic attack one afternoon precipitates a call to a neighbor, and the neighbor takes her to the ER. At the ER, they do an assessment and acknowledge and share with her that she is not at any increased risk of a heart attack. They review how to manage her COPD symptoms, and they refer her back to her PCP. So what might a provider do? A PCP, him or herself, or someone to whom the PCP refers the patient? We might do more psychoeducation. Let's clarify, what's COPD, what's anxiety, what's the risk of anxiety, what's the risk of COPD, and what kinds of treatment of both of these conditions are available. If we think a medication might help, and if the patient is open to that, we talk about the options of starting an SSRI or an SNRI. And then we might ask Maggie to self-monitor. We might ask her to keep daily records of her panic attacks, the thoughts, and the symptoms. This might help her understand how her fear of panic attacks is being misinterpreted as a fear of death. And it might help her see how her panic attacks are creating some avoidance, which then actually leads to increased fear and sadness and boredom and even more avoidance. We might offer Maggie a deep breathing exercise. When she's anxious or uneasy, her breathing gets rapid and shallow, and that can be the start of the panic attack. Helping her learn to breathe slowly, diaphragmatically, deeply is a really simple, portable tool that helps just relax her body and helps her maintain some management of her panic attacks. We also might do what we call cognitive restructuring, but it's really changing thoughts. We might help her explore these beliefs she has about panic symptoms. When I start to have this thing, what is it? And what does it mean? And oh, well, it's just a panic attack. It doesn't really mean anything. It's just anxiety. It's just a high level of anxiety, but it's just anxiety and it's going to go away eventually. By doing this, we help her replace thoughts of death with a reminder that panic is not dangerous and can be managed. This changing thinking is not just positive thinking. We don't just say, oh, it's going to be okay, everything's going to be fine. We help them think rationally about the symptoms that they're experiencing. They feel scary, but they really aren't scary. We also then might address behavior and try to help the person reactivate and reduce avoidance, restart some pleasant activities, going back to visit with your friends, having lunch, restructuring her days to fit her newly retired lifestyle, having lunch with her friends, stop calling her husband for reassurance, get back to going to church and doing the things that she used to enjoy doing. So let's do just a couple of practice cases. I want you to think about, as we talk about the case, what might be the questions to ask, what diagnoses might we consider, how do we decide if the anxiety is normal or abnormal, and what treatment options might we pursue. So let's talk about Theresa. Theresa is a 72-year-old woman with some neck pain, shoulder pain, headaches, and stomach problems. Doctor hasn't been able to find any physical explanation for these complaints. Theresa describes herself as a lifelong worrywart, but she's gotten worse at worrying since her husband died and has had trouble developing a new daily routine. Her sleep has been impacted because her mind is constantly racing with her concerns, and she started avoiding her friends. She doesn't want to burden them with her concerns, and all she's got in her head is this worrying, and she doesn't want to be embarrassed by that with her friends. She feels restless, she cries, she ruminates about finances, even though she actually is financially stable. She ruminates about maintaining the upkeep of her house and how's she going to keep her yard, and is her car going to be okay, and how sad she is that she misses her husband. And she's calling her adult children pretty often to check in with them. So let's think about possible diagnoses. She could have a long-standing anxiety disorder that's gotten worse with the loss of her husband. She could have a new onset anxiety disorder. She could have anxiety and depression related to grief. She could be experiencing normal bereavement or uncomplicated bereavement, or she could have generalized anxiety disorder. Which ones of these make the most sense to you? I think we might consider all of them except for B. B, the new onset anxiety disorder, doesn't fit as well with her description of herself as a long-standing worrywart. Most likely probably is A, long-standing anxiety disorder that has been exacerbated by the loss of her husband. We would want to know things like how long it had been since her husband's death, how did the symptoms change at that time, what were they like before that, what were they like after that, when did this avoidance start? And then we'd want to know also about the depression. So C, anxiety and depression related to her grief. So she might have had anxiety before, now has worse anxiety and depression. And so we might consider treatment options that could address both. CBT can certainly address both anxiety and depression, and SSRIs and SNRIs are also effective for anxiety and depression. How about Alfonso? He's a 65-year-old male, recently retired Army vet. Presents to you with sleeping problems and panic attacks that he's had ever since he retired. His wife is worried that he's not as active as he used to be. He sits in his recliner all day, daydreams, watches TV, didn't join in the 4th of July activities this year, and has become very concerned about safety in the home. He now sleeps with a gun under his pillow, and he makes rounds around the house every night before he goes to bed. So what diagnoses would we consider for Alfonso? Panic disorder, social anxiety disorder, PTSD, obsessive compulsive disorder. Think about which ones might make sense to you. I think we would consider both panic disorder and PTSD. We'd want to know something about his stressful life events, both those that he's experienced recently and any that he experienced in the war. We would want to know more about his history of panic attacks and whether he has had them before retirement and they got worse after retirement, or they just started coming after retirement. We'd want to know what the precipitants of the panic attacks are. Do they come out of the blue? Do they come only when something triggers a reminder of a trauma? We'd want to understand, again, timelines. We want to know about timelines and when people experience which symptoms. We could offer Alfonso some CBT for PTSD, and we could offer him an SSRI. Last case, Lorraine. Lorraine moved to live closer to her adult daughter, and she's had more anxiety attacks since she moved. She hasn't yet visited the local community arts center, although she previously was involved in the arts for many years. She worries a lot that she's not going to fit in this new environment. She's afraid she's going to get lost driving. And she came from Philadelphia, and she's afraid other people won't understand her accent. She used to be very active with art and reading, and she's kind of lost her interest in some of that. She spends a lot of her time kind of dozing on the couch or zoning out to TV. Excuse me, which diagnoses would we consider here? Depression, generalized anxiety disorder, panic disorder. Think about which ones might make sense. In this case, I think we could consider all of these. Probably most likely some combination of depression and anxiety. But again, want some more history about the nature of her fear, some history about the nature and timeline of her fears, worries, panic attacks. We want to know when she stopped being active. Was she starting to be less active before she moved? Did it start right when she moved? We want to know about what is causing, what's the motivator for her reduced activity? Is she just not interested anymore, or is she afraid? This is an important way to differentiate anxiety and depression as a cause for avoidance. If someone is just, I just don't have the energy, I still would like to draw, but I just don't have the energy. That's different than I'm afraid of drawing because I don't want new people to see my artwork. I don't want to have to meet somebody new and they're going to evaluate me in some negative way. Certainly, again, CBT could be useful for depression and anxiety in combination, and we could consider, again, an SSRI or an SNRI. So in summary, please always assess for anxiety. It's an important issue for many people, and they're unlikely to talk about it without you asking about it. Older adults may present with anxiety that meets diagnostic criteria, but also that doesn't, and still causes significant distress. Older adults with anxiety are also likely to have depression. Treating anxiety can reduce depression, but when both are present, treatment is a little more complicated. Anxiety is highly comorbid with medical illness. It may just look like it's overlapping, but it also can be caused by a medical illness. And medication and non-medication treatment options are generally effective. We have a good evidence base. So anxiety is not something that older adults necessarily have to suffer with. We have in this presentation a number of references that you can have access to if you want to do more reading. We do want to thank you again for joining us today. We appreciate your taking the time to listen, to think about anxiety in your older patients. We know your time's very valuable, people are very busy, and so we appreciate your motivation to offer age-friendly care. We also welcome your feedback. So there are, on this slide and in your materials, there is some links to some surveys. We would appreciate your completing those and giving us some feedback so we can improve our presentations. So thank you again for listening.